Okay, so today we're going to talk about network medicine, which is a new discipline that will basically take over medicine as we know it. And I'm going to present mostly concept, and then I'm going to try to show the clinical implications. Medicine is a very active field that evolves continuously, and the introduction of a variety of technologies is helping medicine to progress very, very fast. And it's really important for us to keep up with that, because particularly at the practical practicing level, the field of medicine will undergo dramatic changes in the next couple of decades, and we need to be aware of that and be part of that. So I'm going to talk primarily about not just IBD, but a variety of chronic diseases, because chronic diseases are the main problems affecting humanity nowadays. And the chronic diseases such as cancer, psoriasis, asthma, IBD, rheumatoid arthritis, allergy, these are really what fills up the clinics. So the issue with the complex disease, if we ask, can we cure any of them? And the answer is no. And we can ask, how effective are the current therapies? We know that they are okay, better than the past, but way far from being optimal. So what are complex diseases, these chronic complex diseases? They basically have four fundamental components. One are the genes, and I'll refer those as a genome, the whole complex of the gene, the environment, which we call now the exposome, the microbes, which are not just the gut microbe, but the microbes of the whole body, the microbiome, and the immune response, which is the results of these three influences. So let's look at the genes to start with. For instance, if we look at how many genetic variations are associated with rheumatoid arthritis, a common disease, there are hundreds of them. And the same is true for inflammatory bowel disease. So what happens when genomics took over and we have the facility of doing many genetic analysis, we realize that these chronic complex diseases are associated with a multitude of genes, which really a departure from the past when we thought one gene, one disease. And we have to realize that even though there are many, many genetic variations associated with some diseases, many healthy individuals, perfectly healthy, normal individuals, they do carry these genetic variations. Like in this case, you can see an overlap between normal individuals and Crohn's disease. And this is important to indicate that having genes associated with diseases does not cause the manifestation of the disease become apparent. So many of us, many of you listening and myself, we carry many genetic variations, but we don't have the disease. So what else is important? Well, genes don't work by themselves. Genes work under the influence of a variety of stimuli, and these stimuli come from the environment, from the day-to-day life. From the time that we are conceived and we are born, pregnancy, feeding, and so on, and then we go through life, every event that we go through in life will have an impact on our biological response by modifying the gene behaviors. And how is this achieved? Okay, this just reminds you that modern lifestyles is really not a very natural one. And modern lifestyles basically is a pro-inflammatory lifestyles. From artificial sweetener, they alter the microbiota, emulsifiers, they alter the intestinal permeability, smoking, excess of salt, fat, all of them lead to basically a chronic inflammatory state, which may or may not become clinically evident. So how do the gene work? So the influences of the environment, which are repeated here in this wheel, they basically act on the cells through what's called epigenetic influences. The epigenome is the complex of actions that act on the genes. And the variety of the genes that we expose throughout life determines if at the end we come up with disease or we stay healthy. And this is a very complex problem, and it's lifelong problem. Epigenetic influences are not just before we're born, are after we're born at any stage of our lives. Let's look at the microbiome, the other complex. In the last decades or so, we came to realize that the microbiome is far more important than we have thought in the past. And what is really interesting and exciting is to learn that every individual has a different microbiome. So two healthy persons, number one, and number two, we have microbes in every part of the body, not just in the colon. And we have them on the skin, in the ears, in the axilla, and everywhere. And everybody is different, which means that even though we're perfectly healthy and perfectly normal, we live with different microbiome associations. And the microbiomes are not just bacteria, are fungi, and virus, and probably archaea also. Another thing that has happened, which is really important to understand these chronic complex diseases, is the microbiome in our modern environment has been dramatically altered. In the past, the microbiome was much more rich. And this rich, varied microbiome, both in numbers and variety, really was perfect to create an adaptive and an innate immune response that lead to a normal immune system. The microbiome is the single most important inducer and factor to maturate a normal immune system. Because of our lifestyle being so unnatural and because our diet has changed so dramatically, we have depleted the microbiota, both in disease and in health. The microbiota is not as rich and is not as varied as in the past. And this is affecting our developing of the immune system, and we have altered adaptive immunity, which is associated with increased incidence of autoimmune inflammatory diseases. So one way to look at this is that we are modifying our lifestyle, and the lifestyle modifies the immune response, and with this immune response, we create a lot of chronic inflammatory diseases, including cancer. If we look at the immune system, the immune response in all chronic diseases is extremely broad, extremely variable, and is variable not only from disease to disease, but through even in one disease, the phase of the disease. The immune response that leads to rheumatoid arthritis, to IBD, or for asthma or other diseases is not the same throughout the lifetime of the patient, and is not the same throughout the lifetime of the disease. These are an example in asthma. These are all different types of T cells that have been associated with the asthma pathogenesis, what we call endotype. Endotype means molecular subtype of the disease. And all these factors that I mentioned all affect the immune response. This is a very nice study done in Europe with 500 individuals, normal individuals, and they studied the effect of male or female, the season of the year, the age of the person, the genomics, and the gut microbiome. And each one of these factors affect different aspects of the immune response. The monocyte response with certain chemokines and cytokines, the T cell response, and so on. So basically, everything we do in life affects how we behave as healthy individuals and how we behave as sick individuals. You can see that this is a very high complex, create a very high complex situations because there's so many variables, and each one of us lives in different environment, eats differently, and exposed to different environmental factors throughout the year. This results in a very important aspect that we, at the clinical level, we don't think about very often, which is the fact that basically there are no two people alike in the world. It's like snowflakes. Snowflakes, you know, in Brazil doesn't snow very much, but snowflakes are crystals of water. And even though there are billions and billions and billions of them, there are no two snowflakes alike. And the humans, unfortunately or fortunately, they're exactly the same. No two humans are alike, not even identical twins. They have almost identical genome, but once they're born and they're exposed to different environments, they will create a different immune system, and their microbiota will be entirely different. So if we look what is the importance of the difference between individuals, if we look when we treat patients, why do we get some responses in some patients and in others we don't? Because of individual variability. This is an interesting chart that shows how people respond and have a positive response. In other words, they have a good response to treatment to different medications. And you can see that it go as low as 10 to 30% or as high to 40, 70%. But in clinical practice, we know when we treat the patients with the same diagnosis, with the same medication, we don't know what to expect. We cannot anticipate the therapeutic impact of the drug because each individual is a separate individual. Another example with the development of new drugs like the biologics, we give them to chronic inflammatory diseases and we anticipate the response based on our knowledge of the pathophysiology of the disease, but this is not so. For instance, block IL-17, which are pro-inflammatory cells, is extremely effective and beneficial in psoriasis, but is detrimental and negative in Crohn's disease. So to chronic inflammatory diseases mediated by the immune system, very clearly, in one, the same medication is good, and in the other not only doesn't work, but is actually bad. And if we look at the success of our therapies, the billions and billions of dollars that the pharmaceutical industry invests in developing drugs, what are the chances of success of new drugs? This is a very nice study from last year in biostatistics that evaluated what's called probability of success, POS, during a period of 10 years. And the best probability of success goes between 5 and 14%, which means that no matter how many drugs we develop, the chances of success is minimal. And that's why the cost is so high, and that's why they have such a high failure. If you look, for instance, at cancer, which is oncology, look at how low is the curve of success. The probability that the drugs developed are really enter the clinic and to have an effect. The best is in ophthalmology and in autoimmune inflammatory diseases, which is this curve is about 15%. So we're in a situation where we are able to generate many drugs, but when we put them in a very heterogeneous patient populations at all levels, the genetic, the environmental, the immune, the microbial, the effect is not that good. Which means that even though we spend a lot of time and a lot of money, we're not really very successful in treating patients the old-fashioned way. Why this is so? Because the old paradigm of one genotype, one phenotype, which means one diagnosis and one disease, is no longer correct. In the 21st century, we have a multitude of factors, all of them acting together and acting over time and changing the physiology of the patients or the healthy individuals. And these variations is something that we are not able to detect, and we random treat the patients in a way because we make a diagnosis and we say this drug is effective in these patients, in this diagnosis, let's try it. And that's why we fail so much, which means that we have to develop new way to think about disease, develop new way to think about treatment, and new ways to develop the thought of how we actually should manage patients. So we are living in a world of very rapidly evolving technologies. This is a very interesting paper in Scientific American, which is a highly respected journal. And in 2017, they look at the top emerging technologies, and there's a variety of them. Obviously, there is computing and deep learning. We'll come back to that. But out of these 10, 3 of them are in the medical field. Genomic vaccine, cell atlas, and medical blood test. So what about if we merge, if we combine these medical advances with computing technology? And if we do that, if we associate medical technologies with the computer technologies, perhaps we can have entirely new development and having some breakthrough in how to manage complex diseases. And in fact, nowadays we have at our disposal a large number of modern medical technologies, RNA profiling, single cells RNA, epigenomic analysis, linear traces, and most of us computational modeling. What this does, they look at the same problem, but in many different ways, and they generate a large amount of data, what now is being called big data. The problem with big data is that we as physicians don't know how to utilize them. If you look at the old data, we're doing serology and determine genome was serological method, very archaic and very inefficient. Now we do genomic sequencing and we get these results. We do, instead of agar plate culture bacteria, we do metagenomic analysis, we end up with this information. And in the immune system is the same. So we as clinicians don't know what to do with this information. At least I don't. I don't know if some of you. So we generate more information, but we are unable to extract the value of this information for the benefit of our profession and for the benefit of the patients. So we need to have new approaches. So let's get into the new approaches. So we mentioned omes and omics. What are omes? Omes is a Greek word, and it means the totality of a given field. Genome, proteome, microbiome, and omics is the study, genomic proteomics. What is system biology? System biology is a computational modeling of complex system, computational modeling of the big data. In precision medicine, which is very popular these days, basically is the application of system biology to omic big data applied to the individual variability of the patients. So we are able, we have the tools at least to integrate the big data with technologies that allow us to interpret them and taking advantage of them. How many omes exist? As many as you want. And if you look at here, you can make an ome out of anything. Allergome, bibliome, connectome, cytome, disiasome, cytokinome, and so on. And the University of Cambridge has a website of the omes, which are in the hundreds. The problem with these omes are very large, and all of them work together. So here we have epigenomics, transcriptomics, proteomics, metabolomics, and all of them are thousands of millions, and all of them work together. How can we possibly integrate them and get useful information out of it? Certainly not the way we do now, we practice medicine now. Why? Because there is so much data, and we as humans have limited processing capacity. We can only do, depending on studies that are published, at the most do between 4 and 12 tasks at a single time. I don't even think we can do that many. So obviously, we cannot process the information that omic and big data has generated, and we need something else. And this something else is this, artificial intelligence. Artificial intelligence has much greater memory than we have and can process information much, much better than we can. And we can then access with artificial intelligence the big data. The other advantage using big data artificial intelligence and that we have an unbiased approach. The new computational technologies don't depend on impressions. We as physicians gather information, we say, I think that you have Crohn's disease. I think you have lung cancer. I think you have rheumatoid arthritis. It's my professional impression based on my experience and a very limited amount of information. But artificial intelligence is not biased as we are intrinsically as human beings. And that allows us to create new hypotheses and create new, much more objective ways of making diagnosis and treatment. So what is all artificial intelligence? I'm not an expert, but artificial intelligence actually has been around since the 50s, 1950s, but it's been progressed progressively. And machine learning is an aspect of artificial intelligence, representation learning, and now we have deep learning, which is a way of really analyzing in great details a vast amount of data. And this is an example. We humans look at an ultrasound and they say, this is the right kidney of the patient. And we see an image. Deep learning sees this, sees numbers. And everything that is computer analysis is numbers. And numbers, as they say, numbers don't lie. So what is the advantage of using this advanced technology? In pathology, especially in imaging, it's great. We can see on the left, what we see is H&E staining of a tissue. But if we do deep learning, then this tissue becomes something where we can see distinct cancer cells in deep red from the other cells. We can distinguish immune cells in purple. We can see gene variant expressing cells in green, activation signals in yellow. So computers allow us to see far more than we can see as humans. And in fact, there's evidence that artificial intelligence and deep learning can do much better than we can as humans. For instance, in the detection of melanoma, artificial intelligence is better than any of the most experienced expert dermatologists you can find. Artificial intelligence can make a diagnosis of neoplastic polyp or hyperplastic polyp as good as the best endoscopist. Artificial intelligence is better in determining dosage of tricholimos in transplant patients than doctors. And artificial intelligence can be used to determine antibiotic susceptibility in urinary tract infection. So we can see the machine are getting better than us. And if we're smart, why not to use these technologies to the benefit of our patients? We as physicians have an obligation to do the best for our patients. If the machine does it better than we can, then the machine should be using it. So that takes us to think about disease management and diagnosis in a whole different ways. How can we think that in a way that allows to take advantage of information technology? Complex diseases are basically complex biological system, correct? Now, what is a biological system? A biological system is a network of multiple components. So can system biology, which is a computational analysis of network, apply to big data? And network medicine basically is utilization of modern computational technology where rather than using a little bit of information is to put everything together that we as human doctors cannot do and integrate far more information for the benefit of the patients. The way that we've been doing research in medicine until now is this. Classical biology, we can take the field of investigation, and as we study, we get more and more and more information, but each piece of information is separate. And with this, the result information is not as good as it could be. But if we do system biology, where all the information is integrated, as we create new information, is integrated until we have everything together in what we call the disease interactome. This allows us to discover central mechanisms of disease. We could do molecular classification of the patients rather than clinical, and we can find specific biomarkers and implement personalized therapy. So what's happening, we're switching from a gene-centric view of disease to a network-centric view, where basically multiple genes and multiple clinical phenotypes is what we found in most diseases. So how do we do this? How do we apply medicine, network medicine in a network-centric view? Let's talk about network very, very quickly. Network conceptually are very easy. We have many components and we link them. And we have what we call nodes, the red dots, and we have links. And when we put them together, you have a network. So this is very simple, very logical. Networks exist everywhere. If you read Les Miserables by Victor Hugo, with all these complicated people interacting in very complicated situations, we have a story network. If you look at what happens in real life, where people from DuPont, Johnson & Johnson, Procter & Gamble, JP Morgan, the banks, they all work together to make our life expensive. This is a professional network. But if we join all biological components, we get the disease network. Remember, we are a network. We as healthy individuals or patients, we are the results of these millions of interactions that results in health or disease. What is a network? Everybody is aware of that, but we don't think. What we're doing right now, listening to me through a computer network, this is an integrated system. There are many people, but these many people depend on something that controls them, what we call the controller or the hub, which is the server, Zoom, that allows our communication. What happens if I remove the server? There is no hub, there is no communication, there is no network. If you transmit this concept to a disease, a biological system, if I remove the controller of the system, what happens? I remove the disease. An example of network. Now, we all eat too much. We have excessive food, excessive energy. We end up being obese. We develop diabetes, non-alcoholic fatty liver disease, inflammation, and cancer. These are all interconnected diseases because of one single cause. So let's look at the biological network in a very simple way. Here is an artificial biological network. Many, many nodes, the gray balls. And these can be genes, cytokines, receptor enzymes, anything can be a node, and they are connected. Within the network, there are areas that are more important than others, and they tend to be centralized. There is functional modules that allow the network to function, which is the green oval. And that these green nodes tend to be more important than the gray one. And there is the disease module, which is what controls the deregulation of the network. And this is what controls the disease. And within the disease network, there is a hub, which is a central controller, okay? This is a system that applies not only to medicine, but applies to all network, financial network, banking network, computers network, neurological networks. So how do we use this information? What is important, first of all, we have to get sample from patients, and from the sample of patient, in this case, serum, blood, biopsies, stools, we can do omic analysis. Technology for these omic analysis are widely available, and when we combine them, we have a disease network. This is patient A. Patient has a disease network A. Only this patient has this network. This is patient B, and patient B has a disease network B that only this patient has. So when we analyze patients all together, they may look phenotypically and clinically identical, but each one of them has his own or her own network. And when we do this, we realize that patients that look alike actually can be grouped by disease network. And each disease network has a molecular subgrouping. So this is a subgroup A of patients, subgroup B, and subgroup C. So we need to switch from clinical classification to molecular classification. And only this way we can discover true relevant biomarkers and do precision therapy. So how do we do this? So here we have many, many patients. We do the biosample analysis, we create the networks, and we have this bunch of analyses. How do we put them together? We need integration to computational processing. And this is done primarily today by what is called artificial neural networks. What are they? Artificial neural networks are derived from the neural network of our brain, the structure. But what is interesting and exciting about this is that they get input information like we do, and we get output information as we do. But in between the input and output, there are endless number of layers that the system creates individually and independently, and not us with our preconceived view of everything. And this is the base of deep learning. The information that goes through the artificial network and to the human network is the same, But this system sees in a different way and basically dissect every component, which is something we cannot do. And the outcome of this is the creation of, with this information, of the molecular disease network, which we as physicians cannot do. And with that, we can only detect the central regulator of the network. Once we have this, we find out what kind of molecule it is. It's relatively simple to create inhibitor to medicinal chemistry. Medicinal chemistry basically creates artificial molecules that perfectly adapt to the structure of any molecule you want. So let's create some treatments now. This is our network. Okay, now I develop a drug that acts on the periphery of the network. You know, there are gray nodes and maybe one green node. This drug number 1, number 2, by affecting the periphery, will not impact on the network. And if this is disease network, will not impact on the network. Now I develop another couple of drugs, drugs number 3 and drug number 4. They act on the functional nodule, 2 green dots and 1 red and 1 green. So this drug may have some effect. Then I create 2 more drugs, and this drug will affect 2 nodes within the disease network. Excuse me. This drug will have some effect. Then I create a drug that will act on the controller of the disease network. This will have a strong effect at the clinical level because it's blocking the boss. Is blocking what controls the disease. And if I create a drug that acts on the network controller plus other nodes of the disease network, this will have the best effect. And this explains why some drugs work better than others. And there are computational systems already been published. They show where the drugs act within the network. If they act on the disease network, they overlap with the disease network or far away with the disease network. So we are at the stage where this network approach allows us to predict the efficacy of individual drugs. The advantage of this approach, in addition to being more precise, is that the time it takes to develop new drugs goes from the current 12 years to 3.5 years, which is huge amount of saving of time and money. So to conclude, let's start thinking in a way that is comprehensive, updated, technological, and better. And this diagram, what it does is compare traditional and network medicine. On the left, we see physician-based traditional medicine, what we still practice every day. Here is a heterogeneous patient populations, people with different colors and different mood. Some are sad, some are smiley, and some are serious. We take this population, all of them undergo to the same process. History, physical examination, blood, serology, imaging, biopsy, histology. And we, as physicians, gather these informations. We use our knowledge and our experience, which is variable from physician to physician. And we decide, okay, all these patients are smiling. Must be the same problem. So this is a homogeneous group, group A. All these patients are serious. They're all the same, must be group B. And all of these are sad, okay? So I have this classification, which are clinical, based on the appearance of these patients and my judgment. And what do? I give them all the same treatment. If they have cancer, they get antineoplastic therapy. If they have some type of inflammation, they give anti-inflammatory therapy. And the response will be limited. Now let's switch from a physician-based traditional medicine to an omics-based network medicine. We take the sample of the patients, but rather than doing routine clinical analysis, we do omics analysis, which are unbiased and molecular. And we come up with, rather than this, end up with interactome network. And this population is divided in 4 networks, 1, 2, 3, and 4. And each one of them has molecular classification or group. All these patients, some are smile, some are sad, some are serious, but they're all pink. These patients are all yellow. These patients are all blue. And these patients are all green because they have the same identical mechanism. If I know that this group of patients need this medication. This group of patients will take this, the blue, and the green, and the green. And this is the essence of precision medicine. Precision medicine can only be done through molecular analysis. And it's going to be the big change in pharmaceutical industry and practice of medicine in the next couple of decades. I hope that I've not confused you too much. And I hope you accepted the idea that especially young individuals will be practicing medicine in a very different way. And the reason for that is not so much because you will be going to be learning, to do computational analysis. This will be done by other type of people. Like today we use a surgeon to do surgery in a patient that needs surgery because we decided, right? We're going to have to collaborate with computational biologists, but the information will be through computer analysis, will be incorporated in practice of medicine. And the young people will have to drastically change the way they think. And the reason why this is going to happen, once the insurance companies, they pay for treatments, find out that this is a way to do faster medicine and cheaper medicine, there's going to be no way that we're going to escape from that. We as physicians already are under the control of our medical system, our insurance system, our payment system. It's a reality that is here to stay and will evolve accordingly. And in biology, we say adaptation is the key to survival. We will adapt as physicians and we will survive. Thank you. And now I'm ready to answer a question in English.
Thank you so much.
If somebody wants to ask something.
So thank you so much, Claudio, for your brilliant presentation and as usual, and so insightful presentation. So I believe that we all have many questions.
Good.
Oops, sorry, I don't have a video here. So, yes, so my video, okay. Start my video, sorry. So I believe we all have many questions. And I think I will start. I have the privilege to start with the first question. So, as we all know, we are living a very strange period of time, but with rapid advances in multiple fields of knowledge. And it's interesting to see that the most exciting, in my opinion, the most exciting science happens exactly in this interface between disciplines, right? But according to your presentation, what's going to happen in the near future? So what's going to be of these individual disciplines? So, and also in addition to changes, what kind of changes we'll need to make and to be prepared for this future? So changes in concepts and new methods, new methodologies in general, and also new statistical methods completely different from the ones that we use nowadays. What kind of new skills we will need in the future?
Let's start by making a statement which is not mine. The medical professionals tend to be very conservative individuals. That's because we still go to medical school and we are taught that you see the patient this way, you do a physical examination, you find this finding, then you do blood work, x-rays, and biopsy, and you gather this information, and the book says, if you find these abnormalities, the chances are that the diagnosis is this, and for this, we treat with this. Now, this is it's not incorrect, but it's a very simplistic way because the biology underlying disease is much more complicated than that. So we as physicians are not going to learn computational biology because it takes anywhere from 4 to 8 years to be competent. So we're going to have to collaborate with people that will interpret the computational biology for us. To do that, we're going to have to do, in addition to routine laboratory tests, we're going to have to do analysis through omic analysis or biobanking. In the US, at least, and in many European countries, the major universities have biobanks. The patient comes and donates a variety of samples, from stools to blood to biopsies, And these are stored, and then each one of them is analyzed and create an omic analysis. Once that information is available, it doesn't go to the doctor. We'll have to go to the doctor collaborator with a computational biologist, and will create omic analysis to determine the network of the patients. This is being done today, not in a generalized way, but some of the few biotechnology companies exactly doing this. And with this, we already are in a position of making diagnostic at the level of molecular analysis, determine the identification of the networks, and develop drugs for the networks. This is not going to happen overnight because obviously it's very complicated, very expensive, and requires, first of all, from the physician standpoint, an acceptance of the fact that medicine will change. From the hospital standpoint, it requires an acceptance of developing novel technologies, biobanking, omic analysis. And for the patient standpoint, requires an acceptance that the doctors is no longer there to control every step of the way. There's a much more comprehensive way of making your diagnosis and determine your treatment. What is lacking so far, and is surprising to me, is the fact that pharmaceutical company, they're really still developing drug primarily the old-fashioned way. They pick one molecule at a time, develop a bunch of compounds against them, and they test one by one, which is time-consuming, expensive, and inefficient. And one of the things I try to do when I talk to pharmaceutical companies is to try to make them aware that they have to change, because they will have to do it. The sooner they do it, the better it's going to be for everybody.
Okay, thank you. So
people don't like to change. People don't like challenge. Oh, I like this way. I know what I'm doing. Don't let me do anything new. That's human nature.
We have a question coming from the chat, which is, the question is network medicine being tested anywhere in the world?
Yes, it is. In fact, the reason why I became involved, and I know a little bit about it, because I collaborate with somebody that is a computational biologist with the advantage that he also knows the biology in the field of IBD. And through omic analysis, this person has developed, tools and identified a particular disease network in a subset of patients with ulcerative colitis, and has developed a drug specifically for these patients. Now, this drug is not for all patients. This is very important. It's not for all patients with ulcerative colitis. It's for a subset of patients that have a particular network, and the drug will only work in that subset of patients. And that's going to be the case for every disease. In cancer, cancer is where most of the network analysis has been done. There are mega networks of hospitals that have these gigantic biobanks. And what the hospitals have done, that the researchers have done, the first step was some fundamental. They took these patients and they did molecular analysis, and they showed very clearly in colon cancer, lung cancer, prostate cancer, breast cancer, glioblastoma, that the clinical classification does not match the molecular classification, which means what we do as physicians, it doesn't really match the reality of the biology of the patients. And if we do that, we cannot expect that cisplatin works in all the patients, because only a subset will respond to it. That's fundamentally important. And then the first step is to provide subclinical classifications. Once we have molecular subclassification, then we can develop drugs for each subset at the molecular level, and then we can do precision medicine. And this has been done, unfortunately, in very few places, because the expertise needed to do this kind of studies is still limited. And it's not in the hand of MDs, that's for sure.
And there's another comment coming here with a question from one of our colleagues. She's saying, I think it's so difficult to understand as a clinician And how can we link clinical research with precision medicine? So exactly what you are saying, just say.
Well, whoever asked, the person that asked the question will not do that. Each one of us, and I cannot do that, a tour cannot do that, but each one of us, first of all, has to live in an environment where this linkage is possible. This required to be in an experimental setting for the time being, where all these technologies become available and they are slowly applied. This is a long process. You know, there are many small, in small countries in Europe where everything is easier to do than in big countries like the US or Brazil. You know, the best universities are already doing this. And clinical classifications at the molecular level are already being done. Of course, there's also ethical implications and practical implications. And also it requires education from the patient standpoint to accept that this medication is being recommended by the computer, not by me. And the patient may say, well, no, I want my doctor to tell me what to do for my treatment. But my doctor, basically in the near future, will look at the computer analysis and see what the options are for treatment of this particular subset of patients and will approve what the computer determines. Medicine will be less and less human dependent and more computer dependent, which is exactly what happens outside of medicine. When we go to your bank, it's not the teller that gives you the money, it's the computer. When you pay your taxes, you pay the taxes to a computer system that checks if you paid right or not. And that's the whole world is run that way, except medicine.
That's right. So I think we have another question coming from an ex-student. So Claudio, would you like to?
Hello, Fiocchi. Actually, I have 3 questions. Just what's the economic impact that you think is going to take to get all these omics? Because just for example, are you hear me?
Yeah. What is the?
I have 3 questions. What is the economic impact to get all these omics? Because just to have an idea, just the microbiome, if you perform this study, is not a cheap experiment. It's a little bit expensive, and you get all the other different omics that you have to include to get the network medicine. And this is the first question.
The second one by one. Okay.
Right.
Cost is always an issue, obviously, but everything is expensive now, but used to be a lot more expensive. Everything we use in medicine biology was more expensive. I wrote a paper with a colleague when I was at Case Western Reserve on the very first genomic analysis in IBD. And we used 4 chips. Each chip was $4,000. This was about 10 years ago. Now that chip costs less than $100. So as the price goes down, you know, all become cheaper and more will be done. This is a law of economics, and this will be exactly what happens with all the cost of the omics analysis. A whole genome analysis used to be millions of dollars. Now it costs $1,000. So as the cost goes down, the application becomes feasible.
Okay, yeah. So I just have actually just one more question. Do you think you have to have new studies or to prepare scientists to be able to perform this network medicine, or do you think what you have right now is enough?
Nothing is ever enough because knowledge keeps growing. As we create knowledge, we create more problems for us to solve. And but until we find a system that provides all possible information, we're able to compute all information. You have to remember that just because we have a lot of ohms, we still don't have the capacity of integrating as many ohms as we like, because the computational systems progressively more and more sophisticated as we test them and develop them. We cannot take 20 ohms and put them all together yet. We can do 3 or 4 or 5 and get some meaningful information. Also, all this, the ohmic information has to be analyzed in the context of the clinical information. Well, in the slide, there was something called EHR, electronic health records. If you do ohmic analysis outside of the clinical information, the results are not correct. Because the behavior of the patients, when the disease started, how it behaved, if we respond to medication or not, all that has to be computed. So it's very complicated, and information grows, and then analytical capabilities grow depending on how much information is created. It's a process of combination of practical, logistical, and economical issues. Obviously, we need also create and expand the class of people that can do this type of analysis. Kids that go to college in the US or university in Brazil, they tend to be more and more attracted to computational analysis and studies. I reviewed a paper recently where the methodology for analysis and multi-omic analysis, they were using a computer system developed in Brazil. I was very impressed and very pleased to see that. So there's going to be a whole new class of people that we need to collaborate with, that they will interpret the omic analysis for us. The MDs were not going to be the one to do it.
I think we have
You're
some
a PhD, maybe you should do it.
He has time.
He has time and he's young.
And we have some more comments. One of them is from Katya. Certainly open mind presentation, but since the biology underlying disease is so complex, discovering individualized targets for specific therapies would be revolutionary. I ask, how about the accessibility of that for our country?
Accessibility now is limited everywhere, but you know, what is accessible in each social environment, it depends really on the environment. You know, we tend to look at the US like the place where the best and the most is there. That's not necessarily true. In medicine, I think that Europe is doing better than the US because they have socialized medicine, which is much better than ours. So the access to all these new technologies really depends on where you live and where you work. If you go to Afghanistan, obviously you cannot expect to have this available. If you go to Holland or Belgium, you'll have better stuff than we have here in the US. So to have access depends on where you are, because to implement what I mentioned is very time consuming, very expensive, and it's either in the hand of the private sector, which means the insurance companies, or the government. And unless you have a political system in which the private sector and the common sector are fused together, you know, you're going to have to depend on one or the other, and this will slow down. So, you know, it's like you move to one place to the other because the other is better, give you more opportunities. More opportunities of any type, and professional and medical is the same thing.
We have another comment here coming from Marcel Land, one of our colleagues. With the development of new drugs directed to molecular targets, we are seeing side effects on organs and systems that seem very unlikely. This phenomenon shows us that we are in fact interfering in networks that we know little about.
I understand. That's a reasonable concern. But the advantage of doing the network analysis is that the drug only act on a single target. All the drugs that we use today, they act on the target that was developed by traditional biomedical, biochemical analysis. But we know that the drug has many, many side effects. Why? Because they're not affecting just the assumed target, affecting many other targets at the same time. By doing molecular analysis, you can develop something that is only affecting one single molecule. And you can take the question on the other hand. If you affect a single molecule on a very complex network, how effective they will be. And those are questions that the future will help answering. But the specificity, which is translated in clinical level as precision therapy, that is going to be much, much, much better. Will be better than ever.
And Dr. Fiocchi, assuming that new qualities will be necessary for the successful interdisciplinary.
What? New?
Sorry. Oops. Yes, I'm
assuming that new what?
New qualities. Qualities and skills and new skills for our super specialized teams that we might have. So do you think academia is getting prepared to that? And what about the funding agencies? What they are doing about that? And if they are, what do you think of what's going on in the US, for example, in terms of funding agencies and the academia? So, or do you think this will be completely taken over by the big pharma?
Not in the early phase of this processing. You know, there are some couple of articles. There's a lot of articles about artificial intelligence replacing doctors, eliminating medicine, and so on. That may happen in the distant future. But the question now that is addressed in several articles, and I actually addressed that when I talk to medical students, is should MDs be learning these new technologies? And there's a couple of editorials in the New England Journal of Medicine, one in 2018 and one in 2019, I believe, that address exactly that issue. And they ask the question, should doctors be learning these technologies? Well, and the article doesn't give an answer. I can give you my impression. Doctor will never have the time to learn medicine and these technologies. But the doctor should be aware that these technologies exist and what their potential is, how can be applied. And then they will have in the future, once this technology provide practical information, like, okay, your group of patients have this network and you should give this medication. That should be a collaboration between computational biologists, computational biobiologists, and the doctor. And that is going to be inevitable. And depending on progress, you know, maybe one day, our medical school, our College of Medicine, already has classes on this. And other, centers like in Boston, they're already giving MD students information about computational biology. Provide, this methodology exists, this it can take. But that's different from actually sitting in front of the computer and inputting, millions pieces of information and then pushing on the keyboard and get the information out. Because then when information comes out, there are 15 million pieces of information. And what do you do with that as a doctor? Nothing.
This is exactly, I think, response to a question from Ivan, one of our students. How should network medicine change teaching in medical schools?
Yeah, he has just answered, yeah.
Exactly.
That's a question that everybody wants to have an answer, but it will eventually teach. Like I am already doing that, and we have another faculty that does that. And so that everything is progressive. You don't change systems in any system drastically. Everything is a process of giving the idea and introducing piece by piece and incorporate. And in fact, the most important thing that MDs and the students have to do is accept the idea that there are drastic changes coming.
There is another question coming from Beatriz.
Hey, hey, good afternoon. I would like to know on the ethical point of view, how could that have an impact on society? Like, I could perhaps do my molecular analysis and find out that I have gene for a disease, and that perhaps could change the way I am hired by companies, or the way that my insurance is gonna look after me. So how could that have an impact on an ethical point of view?
Yeah, that's an ethical question, not really medical. But, you know, if you look at the reality of life that we live, modern life, with all this technology basically controlling our lives, the future that I see, that people say, oh, no, that's never gonna happen. It will happen. You know, as soon as somebody is conceived, the fetus will be analyzed and we'll have a complete genomic analysis. And with that, we'll have a list of risk for disease. Do we keep that information private for the parents, or will that information available in a public fashion? If you look at history of humanity, information is seldom kept secret. Information is always divulged. Information always, as we say, leaks. That's going to be a big issue because it depends on what government, what society you live in. The patient will have access to that information. The question is, should that information be made available to your future employer, to your future husband, to your future wife, to your future whatever? Those are questions that are too big to answer. I personally think that for each one of us, no risk of our DNA or potential diseases is not useful. Why? Because you say, oh, you have a risk of 1% for diabetes, 5% for lung cancer, 10% for dementia. Okay, then what? What are you going to do about it? Are you going to change your lifestyle because of a 1% risk or a 5% risk? At what cost? The most difficult thing to do is not to treat patients, is ask the patient to change your lifestyle. The patient has lung cancer. Did you stop smoking? No. Why? Well, I have to smoke. You tell the patient with Crohn's disease, stop eating this or that. They will not do it. We know that. So that's a human part, which is not controllable. I'm not in favor. You know what 23andMe is, right? 23andMe? It's a company in the US that you can, they send you a little kit, you put a swab in your mouth, you take the DNA, you send them back to them, and for a few $100, they tell you, oh, your risk of disease is blah, 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 blah. Okay, then what? Then depending on your personality, you say, oh my God, I'm gonna have cancer. And other people say, oh, this is nonsense, I don't care. And you know, there's no practical way of using information in a meaningful and helpful way today. And that really depends on you, your religion, your society, your parent, your education, your personal beliefs and stuff. Those are, in the US, we say it's a loaded question. Loaded means it's a huge question. There's no answer for that. Sorry.
Thank you.
Sure.
So I don't, let's see if we have.
Can I ask a question?
Oh, yes, please. Please.
Thank you very much, Dr. Fiocchi, for this excellent talk. My question, in fact, was done by one of the students here, but yeah, but I want to reiterate the question, because one of the most important things that we are trying to teach to these bunch of students, all of them very, very committed to the graduate courses that they are doing, is that they have potentially a career as an academic, as a scientist, as an investigator. And as an investigator, probably the way investigation is done in the world now is that you will have to focus in probably one molecule or one target or one receptor. And these will not disappear from the panorama if you consider exactly what you're doing, what you're saying, because we still need to know each one of these small targets to continue. So it's exactly the summation of all this information that will allow us in the future to do this sort of a more global analysis. Is that, it's more a comment than a, a question to you.
Yeah, so system biology does not replace classical biology, because without classical biology, one cannot do system biology. Okay, where does the data come for system biology? From classical biology. But it's the way that we utilize each one of them. The way that we taught, the way that I've done research all my life is focusing on a particular molecule, particular cell. Why? Because that was the way that I learned, and that was the way that was supposed to be done. And at that time, and it's still today, is correct. So from an academic standpoint, where to focus really should be the choice of the individual. The young doctor, the young PhD should choose what to focus on scientifically for a career, depending on where. A career in academia, as you know better than me, is only successful if you love what you've chosen. It's like being married. If you don't marry to the right person, it's not going to last. But if you do what you really like, then you keep doing it and doing it, and you get better and better. So if you become a classical biologist or a computer biologist or a system biologist, it really depends on the choice and depends on your brain. I talk about system biology, network, but I hate mathematics. I hate computers. The only subject I failed in medical school was biostatistics, 3 times, because my mind doesn't work that way. But conceptually, I can see that. And that's exactly what the future academician has to do, is to fall in love with a particular area and keep doing that. If it's at a molecular level, a biological level, or statistical level, that should depend on the person. Creating new information is important, period. So there's no wrong area to go into. Now, there are also fashions. Medicine and research is very fashionable. You know, there is something is important. Everybody studies that thing. Then something new comes up. What was so important now is no longer so important because the new thing is more important. And that's the way we see life. Everything that is new is more important. Right now, everybody is doing single cell analysis. Single cell analysis, single cell analysis. Why? Because this technology allows to do that. The information that comes out is almost irrelevant, but it's a thing to do. So it really depends on the time frame that a person is in, but basically the most important thing is to do something you like.
Thank you, Claude. And I think we have a last question here. I'll read it for you. Theoretically, the deep learning protocols are able to learn to recognize patterns better and better with the input of new information. This would imply a degree of cooperation and information sharing never seen in repercussions, with repercussions on copyright and research funding. How to build this new cooperation system in the health area?
I don't think that I'm qualified to answer that. But also, I think that we're still not at that level. It's good to think about it, but I don't think that we have enough information, enough situations that can teach us how to go. This is an area that really requires a different expertise, different knowledge, and I'm not qualified to answer that. I'm sorry.
So, but I think we are on time, and I thank you very much for your wonderful presentation and for your time, your patience, and that was a good, excellent opening session for all of us, and I'm very glad to the participation of our students, and on behalf of the program, I would like to thank you again very much, Claudio.
Thank you. It is me that I thank you. It was a pleasure, and it was really an honor for me to be the opening speaker, but also was very happy that so many people ask questions. Usually when I go to Brazil in the past, when we could travel and give lectures, live lectures, you know, I usually don't get any questions. So I think maybe the Zoom system, the virtual system, removes the shyness of the young individuals and they ask questions, which is good. Okay. Thank you very much to all of you.
Thank you. Thank you all. Thank you, Claude.
Thank you, Heitor.
Bye-bye, Claude.
Bye-bye.